I'm with Dr. Lorne Scharf here at CCH in Cornwall, Ontario. Dr. Scharf, you're one of the protagonists that brought in the new Telestroke program. Can you tell us a little bit about it?
Yeah, the Telestroke program is something that we're very proud of. It's a regional program that was developed to bring a cutting-edge, sort of state-of-the-art treatment for stroke to our community, something that was previously only available in large teaching centers. And what it does is it implements locally with the remote use of specialists in teaching centers by teleconference to our hospital to deliver very expert care to people having a stroke.
So what are some of the advantages of it and the innovations?
So just to start off, stroke is a really bad disease. In terms of treatment of stroke, there's very little. You really want to prevent a stroke. You want to prevent a stroke by not smoking, by controlling diabetes, by controlling cholesterol, the cardiovascular risk factors. Once a person has a stroke, they really are limited in terms of what can help them rehab, further control of risk factors. But we began to see in the last 10, 15 years that this new therapy, where we were dissolving the clots in their blood, was offering some hope for the acute treatment of a stroke when it was actually happening. So this is a treatment that we borrowed from the cardiac world, these clot-busting drugs. And if you have a heart attack and come to the emergency room, we give you a shot of these clot-busting drugs and they open up the artery to your heart and your chest pain melts away. It's a very dramatic thing. With a stroke, it's not as dramatic in terms of how things turn around. But if a person does develop a stroke, all of a sudden they can't speak, the side of their face is weak, or they can't use an arm, some kind of acute neurologic deficits. If they develop something like that, they come in, and if they meet our criteria for showing that they're a candidate that would benefit, we can give them the clot-busting drug.
So most people don't actually know what a stroke is. Can you expand on that a little bit?
So a stroke is when you have a problem with the brain function due to oxygen not getting a part of your brain, and that usually means that a blood vessel and artery is blocked by a blood clot.
But blocked or burst?
Well, there's two main different kinds of strokes, the ones that are bleeding and the ones that aren't. And this is actually very important for Telestroke because we're thinning their blood as a treatment. So if it's a burst artery, we don't want to do that. So you can have a stroke where there's a bleed, or you can have a stroke where there's a blockage. The bleed, that's a whole different topic. And thankfully, that's the vast minority of strokes. Most strokes is a blood clot blocking an artery. And that's why we have this window of opportunity to improve the outcome of stroke by dissolving away that blood clot.
So compared to before Telestroke came to CCH, how dramatic an impact is it going to have? Like, what's the real difference?
So the real difference, and I don't want to bore you with too much of the scientific details here, but the real difference is that it's extremely time sensitive. So there's a lot of research and evolution here. There is a lot of new data coming out. There's a lot of reanalysis of the old data. It's not so easy to figure out who are the best patients that will benefit from this, which patients to not offer the therapy to. What is clear is that patient selection is really critical and timing is really critical. So as the data and as the research comes out, we're able to better select who we offer the therapy to, when we do it. And what we know is that there's this window of opportunity within which to give this clot-busting drug. And if you can't give it within that window, you're done. After that point, it actually increases their negative outcomes. It actually causes harm. So we need to get it to them and get it to them quickly. And within that narrow window, they need to have a CAT scan to make sure there's no bleeding. They need to have an evaluation by a trained stroke neurologist, and this is going to be somebody in Toronto or Ottawa, sometimes in Thunder Bay, and they need to have that evaluation, and that's what we're doing now on Telestroke over this closed circuit.
So you don't have to have the doctor present in the hospital anymore?
Well, that was a deal breaker before.
Yeah.
So now what happens is they come in, we immediately activate the system. Very often the ambulance will let us know they're on their way with a potential code stroke patient. As soon as the doctor on duty recognizes that this person is a potential code stroke, they are within that 3-hour window of being treatable. We trigger the code stroke protocol. They immediately get a head scan. They immediately get hooked up to the Telestroke network. So our phone rings. We're now on the phone with a neurologist who could be anywhere at a teaching center in the province. that neurologist can look at the CAT scan. So they're hooked up via an IT system, which allows them to actually see the pictures, make sure that there's nothing bleeding, make sure that everything looks like it's a good candidate for this kind of program. And then we go and we redo our examination of the patient with the neurologist watching us on a camera like this. The neurologist will tell us, okay, check their reflexes, get them to squeeze your hands, show them your keys, and ask them to describe what you're showing them. There's all sorts of ways to check the different parts of the brain.
So besides saving lives and also long-term impacts of a stroke, ultimately it's going to save the healthcare system money.
So the outcome that we think is positively impacted by Telestroke is the 30-day outcome. So when you give somebody a clot-busting drug for a heart attack, it's amazing how they just get better in front of your eyes. With a stroke, they don't. It's a bit of a delayed thing. What we're doing it for is the 30-day outcome. So there are scales of disability measurement. And these are validated scales that are developed by the occupational therapists. They look at things like, can you dress yourself? Do you need help with your activities of daily living? Are you independent? Are you going back to work? Are you gardening? So they look at stuff like that. So we know on the 30-day outcome, by giving them this clot-busting drug, if they're the right patient to get it at the right time, then we can move them up a few notches on that scale of functioning. And it can mean the difference between living in a nursing home and living in the community and gardening.
What percentage of stroke victims would this impact?
Well, the minority, unfortunately. And once again, we're still refining our selection criteria. We need to get them here quickly. If you think you're having the symptom of a stroke, you really want to see it.
What are the symptoms of a stroke for people that don't know?
Yeah, so it's a neurologic thing. It's paralysis of a limb. It's trouble speaking. It's slurred words. It could be a drooping of the side of your face. It could be visual symptoms. It's unfortunately kind of vague, and sometimes it just goes away without treatment. A lot of other things can confuse you for it. If your blood sugar is low, or there are even other things that can make the muscles on your face weak. There's something called Bell's palsy, and so there's a lot of mimics that could look like it. But if anybody has a neurologic symptom, they should really be seen in the hospital right away, and let us make that determination of whether or not it could be a stroke, and that will give us the opportunity to give them that therapy.
And if people want to learn more about Telestroke, is it on the hospital's website?
I don't know if it's on the hospital's website, but they're more than welcome to reach out to one of the leaders in the emergency department, our team leader, or myself, and I can tell them all about it. And it's a very powerful therapy, and we're lucky to have it here in Cornwall. It's really a good example of the province taking leadership. It was the teaching centres that offered to support us through this, and they helped us implement it. And they really helped sort of broadcast and implement this in the communities so that everybody in Ontario in a small community such as this could have access to a tertiary level program.
All right, thank you, Dr. Scharf.
Thanks, Jamie.